My name is Ellen Schwartz, and I'm a proud member of the Healthcare is a Human Right campaign. This event is part of a series of nearly 20 community forums that are being held statewide. This community forum is sponsored by Put People First, the Healthcare is a Human Right campaign of the Vermont Workers Center, Single Payer Now, along with other coalition members of Vermont Leads, who are the Alliance of Retired Americans, Federation of Nurses and Healthcare Professionals, AFT Local 5221, United Professions of Vermont, Vermont AFL-CIO, Vermont Center for Independent Living, Vermont Cancer Association, Vermont Early Educators United, AFT, Physicians for a National Health Program, Vermont Healthcare Ombudsman, Vermont NEA, Vermont Healthcare for All, VCCH, Voices of Vermont Children, and VPIRG. I'd like to tell you a little bit about us. The Vermont Workers Center is a statewide grassroots organization that has seen the healthcare crisis grow for many, many years. In 2008, we finally kicked off the Healthcare is a Human Right campaign to bring the people of Vermont together to address this crisis. Since then, we've organized in community meetings like this one, candidate forums, knocking on doors, conducting surveys, and much more in order to find out how people in Vermont were experiencing the healthcare crisis and what they wanted to do about it. We have organizing committees of members and volunteers in every county of the state who are working hard to make sure that our new healthcare system reflects the values of our communities and meets everybody's needs. We're hosting these forums together because we believe that Vermont can be the first state in the country to lead the way on a healthcare system that is universal, equitable, and accountable to the people of Vermont. We think the only way for us to get there is for us all to be part of the process of making important decisions about the design of our healthcare system. We all have a lot of questions about where we're headed on healthcare in Vermont. With big fundamental change like this, there can be a lot of misinformation and fear. In fact, instilling fear by means of misinformation is the primary tactic of opponents to the healthcare system reform. We are here today to get on the same page and answer as many questions as we can. You're going to hear things, not today, but out there in the world, like this will bankrupt Vermont and drive small businesses out of the state. But we know that we need health care for all. If you hear something that scares you, contact someone who's involved with the campaign to get accurate information, because what you're hearing is likely to be fear-mongering. Today we're going to present on how we got to where we are today and where we're going next in Vermont on healthcare, and then open it up to questions. The agenda for this evening is, after I'm done with this little welcoming part, we're going to hear about why change is necessary, or another way to think about that is what's the problem, what the solution is, what actions we can take, and then we'll have the question and answer time. So I encourage people to hold your questions and answers until that point, unless the question is a clarifying question, like if you don't understand what somebody's saying, that would be a good kind of question to interrupt with. To get us started, I'd like to introduce fellow campaign members Mary Garish of the Vermont Workers Center and Richard Davis of Vermont Leads Single Payer Now.
Hi,
here,
my name is Mary Garish, and so I would like to tell you a little bit about why we're here, and that is because we all need health care. And you probably hear a lot about, in the news lately especially, about how a large percentage of Vermonters have health care, and a large percentage of Vermonters are insured compared to other states, so we shouldn't be worried, but we all know that's not true. Who here either has or knows somebody who has insurance but can't really afford to use their insurance? And who here knows somebody that hasn't gone to the doctor because they can't afford it? Who knows somebody that doesn't get dental care because they can't afford it? I think that's very common. Hi, come on in and welcome. So what we're here today to talk about is how we can change that. And we as the people of Vermont, and you as the people of Vermont, have already made really large steps to change that. But we did that in a lot of ways, and One way was by telling our stories and letting our legislators and our neighbors and our friends know about the human suffering that we were experiencing by not being able to access health care. Even people who have insurance sometimes can't afford to use it because of deductibles or copays. So at this time, I would love to introduce Lynn Akey, who would like to share some stories with us. And Lynn, would you join us, please? Do you want this on the...
My name is Lynn Akey. I live in Brattleboro. I'm a member of the Vermont Workers Center and Put People's First campaign, and healthcare is a human right. I would like to thank the community for coming here tonight and taking the time to hear about our healthcare reform and how the members of Shumlin administration did not include dental and vision in our benefit packet. Well, I'm here tonight to say we want and need dental care in our universal health care coverage. This is about our quality of life. We can't afford not to have dental. Let's think about the meaning of the word universal. Refers to, applies to all, or as a whole. I believe our teeth are part of our human body, a very important part of our body. In our society today, there is a huge concern with obesity, diabetes, heart disease. Dental is a serious concern, and proper dental benefit care should be in that packet. I was fortunate to have grown up being able to go to the dentist. I got my first cavity that was filled at the age of 18. I had beautiful teeth. As an adult, I had to go through having both hips replaced. The medication I was taking made my teeth break off at the gums. The end result was all my top teeth had to be pulled out. Not only physically, but also emotionally, I was devastated, which now caused the depression. Do you see where this is going? I personally see this going into a vicious cycle. So now, not being able to eat fresh vegetables, fruits, and nuts, my bottom teeth were building up with plaque, which causes gingivitis and other gum diseases. Even though I go to the dentist twice a year, it's not enough. I need to go at least 3 or 4 times a year for a cleaning because I can't eat the healthy foods that prevent plaque buildup. Now let's talk about dentures. Dentures are not just for cosmetics. As the chewing of our food is the first step in proper digestion, and to be able to eat these healthy foods, vegetables, fruits, and nuts, it's so vital in our nutrition. Our diet has a significant influence on our overall health. And the health of our teeth and gums can cause serious overall health risks. It took me 2 years to save enough money to buy dentures, and I went to Affordable Dental. So eating healthy, taking care of our bodies will cut down on obesity, diabetes, heart disease, and depression. Adding these benefits will have the positive effect of lowering state expenditures on health care and hospitalization, monetary statistics. Our voices need to be heard. We need to fight this next battle for dentures and dental and vision and get this into our universal health care coverage packet and put people first. Thank you.
Thank you. Richard, did you want to say something about how broken our current system is, and
Yeah, you got a couple of weeks.
yeah, exactly.
Well, first of all, I just want to explain the organization that I'm representing right now is Vermont Leads. It's a newly formed single-payer group that started in June. It's 501c4 as opposed to a C3, which means that it can do some political work, which is good because we can counteract some of these ridiculous ads that are coming out now. So that's one positive thing. But the organization primarily exists to educate Vermonters about the need for a single payer, and now that we have the governor and his team working and moving in that direction, that's good, but it's not enough. So there's groups like the Workers' Center and Vermont Leads. The more we have, the more power we can generate to get there. So some of the things about the system, I'm sure most of you have heard these things before, but they're worth repeating because they're so disturbing. But even though Vermont is one of the better states in the country in terms of health coverage and insurance, we still have 47,000 uninsured people, and in addition, most estimates are that about 160,000 people are underinsured. So those are the people that have insurance that can't afford to use it. You know, it's a very common problem. So in those people, what health insurance becomes, it's bankruptcy insurance. It's not health insurance. They get the insurance because they're afraid that if something really catastrophic happens, they don't want to lose everything they have. So they'll pay out all this money, not use it, and use the insurance to protect them against bankruptcy. But the statistics on bankruptcy are pretty appalling too. 50% of bankruptcies are as a result of medical bills that people can't pay, or they pay them and they go bankrupt. It's pretty staggering, and they've done a few studies, and the numbers don't change much. 80% of the people who go bankrupt because of medical bills work full-time or have family members who are working full-time, so they're not one class of people. Another problem with the system as it exists is that more and more employers are shifting the cost of health insurance to their employees. It becomes unsustainable. It means that as the cost of health insurance and health care goes up, somebody has to keep paying these increased prices, and employers traditionally have borne the burden of health insurance, but it's an outdated model. It originally started in Germany in the 1860s with Bismarck, and we adopted it in the 1930s and the 1940s in this country, but it's a model that really doesn't make any sense for us anymore. And the primary reason that it was created in Germany was it was a union busting tactic to stop the unions from organizing, because they were offering health insurance, and the employers wanted to compete against the unions, and so the history is very perverse. And right now, I think most people who understand health care reform realize that we have to uncouple health insurance from employment. It just doesn't make sense anymore. Half of uninsured people are eligible for Medicaid, the program for poor in this country, but they don't enroll for whatever reason. There was a survey done in Vermont that showed that 70% of the people don't enroll because of cost. So not all of Medicaid is free. There are different levels of Medicaid in Vermont. We have rich benefits, but at the different levels there are different cost-sharing burdens, and even when the cost-sharing is low or minimal, a lot of people can't afford it. In Vermont, 74% of working adults between the ages of 18 and 64 lack access to insurance by their employer, either because the employer doesn't provide it or they can't afford it. And the unsustainability of health care is clear when you look at the spending in health care. It's astronomical, but like from 1992 to 2009, so that's like 17 years, just in this state alone, it's gone from 1.3 billion to 4.7 billion a year. I mean, that's unbelievable when you think about it. And then we were given hope that the federal bill, the ACA, was going to help us and move forward. Well, in some ways it has, but it created these exchanges, and this is what we're locked into now. And as much as the right wing and the Republicans are railing against this government takeover of health care, that's not what it is. I mean, I can only wish that it was, but I mean, it isn't. And what the exchanges are, it's a continuation of the private market system. So what happens is there are subsidies that go along with these exchange plans, insurance plans, and the subsidies are coming from tax money, but the subsidies are paying for private health insurance. So it's another crazy setup. That's what happens when politics is the primary driving force in healthcare reform, and you end up with things that just don't make a lot of sense. And unfortunately, even with this ACA and the exchanges, even with the subsidies, there still are going to be plenty of people, a lot of people, who won't be able to afford even the insurance that's in the exchange, even with a subsidy. You know, and in Vermont now, what we're trying to do, working with legislators and policymakers, is to try to keep that cost sharing and the subsidy at a level where people won't be denied insurance because they can't afford it. You know, and that's always a struggle, and it's always what we're aiming for, is to make things affordable. It can't be universal if it's not affordable. So those are, you know, maybe some more. I hate to throw out statistics a lot, but sometimes you need to hear the numbers to understand the big picture. And so that's just sort of a thumbnail sketch of where things stand. And then as you just heard, the dental issue is really big right now. And from what I've heard, the Green Mountain Care Board was going to decide this week on the dental benefits package, but they heard from so many people, they got over 1,000 responses, that they delayed, which I think was a good thing. So from what the latest I heard was that next week they're going to have a meeting and they're going to announce what their plan is. I'm assuming, that's just an assumption on my part, I have nothing totally to base this on, but I'm just assuming that the reason they delayed is they're trying to figure out where the money's going to come from, because that's part of what they have to do. So, of course, you know, the simple answer is pay dentists less, but it doesn't work that way, because if you want to understand why the free market system doesn't work, just look to dentists and dentistry, and that'll explain everything. I mean, that should be the model that we're moving away from, but that's a good example of how not to do health care. So anyway, those are a few little bits and pieces.
When you were talking about the exchanges, I got confused when you were talking about the federal plan and when you were talking about the Vermont.
Well,
because I don't think they're the same.
Well, the exchanges, the rules for the exchange are federal rules.
Yeah.
And every state has the ability to tailor the exchanges, so how they set those up, there's some leeway. What Vermont wants to do is, well, you have to have at least a certain number of choices. It's like 3 choices of different plans, and the plan, the lowest cost plan has to be equal to certain benefits, and they've delineated what those are. But the companies have to, you know, bid on if they want to be part of this program. So you have to have at least 3 insurance companies within the exchange. So there has to be 3. So we're looking at probably Cigna, MVP, and Blue Cross. Some insurance companies are more enthusiastic about this than others, but so it's the federal rules create the program. The state, some of the state laws apply, but the money it's a federal subsidy. So
So the reason what you're saying is that Vermont's final plan that I thought was supposed to be different from the federal was that I thought we were getting funding from Medicaid to do that.
well,
I did not know that we had to do it the way
No, this is the first step. We have to do it according to these federal rules. What Vermont is looking for is a waiver,
I know they're looking for a waiver.
but we don't have it.
If I might just interrupt for 1 second, I might be able to clarify this. You, the people, were in motion to get Act 48 for universal health care passed before the federal law got passed. When the federal law got passed, the government was basically saying, some of the states are cutting back on health care way too much, so we're going to set up these minimums for insurance. We weren't very happy because we were trying to move away from insurance and move towards single payer. So until we can get there, which is going to be at least a couple of years, we have to put up with an insurance-based system. And the exchange that's created by the Affordable Care Act is kind of like an Orbitz or a Travelocity for insurance. You know those sites that you see ads for where you can go and book a trip with all kinds of options and hotels and this and that for the cheapest rate. That's basically what the exchange does. That doesn't help us get health care any. And I think that's your point.
No, my point is, you're talking about two different animals. You're talking
Right.
about between 2012 and 2014, and that
That's
was
correct.
not made clear to us.
That's
It sounds like you're talking about what Vermont is going to be, and that is not what it's supposed to be.
No, wait. The exchange will be in place until most likely 2017. 2017, because the federal laws that govern the exchanges and the Affordable Care Act don't allow for waivers until that year. So what the hope is, I mean, some people are hoping this whole exchange thing just blows up and it doesn't work, because then it'll prove that, you know, it's not the way to go. But what Shumlin administration and what the people in the policymakers in Vermont are hoping to do is to get a federal waiver that will allow them to say, for the state of Vermont, that we will have one insurance plan. It'll be the single payer plan. One plan that the state will set the rules. They could farm out the administration to Blue Cross or somebody. It doesn't matter who administers it. But the rules will be dictated by the state of Vermont, so it will be a single payer plan. We can't do that until we get these federal waivers, and clearly any politician that I've talked to, Bernie Sanders, any of those people, as much as they'd really like to have it happen sooner, clearly it's probably not going to happen until 2017. But in the ACA, in the federal bill, there's a provision for all of that to happen. It's already there, so we don't have to change anything. But that will kick in 2017 unless, you know, the Republicans try to mess with it.
Or unless, additionally, there is a provision that the Executive Office of the President can give a waiver earlier than 2017.
Right, which I wouldn't hold my breath on that.
Well, I don't know. There have been verbal commitments to do that, but certainly till after the election, we'll never know.
When we
But
went to these workshops last year,
yes,
there was no mention of this at all.
that's because of the fact that it wasn't until the Supreme Court affirmed the ACA as being a, quote, valid law, which just happened this past spring, that we really knew for sure we were going to have to deal with it. But when the legislator wrote Act 48, they included, it's like half the act has to do with the federal program and the exchanges, and the other half has to do with where we're going, which is universal care. So when we talk, it's very confusing to everybody, even people that work with it every day. Richard may not be confused, but I am, I know. And so it's very confusing to think about. But what Richard is talking about right now is how we're sort of, our hands are tied by the federal law, but we're trying to still get the single payer through, even though there's insurance companies involved. And this year, there was a victory in that the legislature voted that policies couldn't be sold outside the exchange. So the three carriers that Richard just talked about will be the only ones to be selling insurance for those things within the state of Vermont, which helps us move towards the single payer.
So the plan for businesses to be offered a plan that was supposed to be a real carrot. I've been reading articles that a lot of businesses
I don't, I'm sorry to take up so much time, but I think this is an important question. I don't believe that a lot of businesses aren't going to do it. I know the Chamber of Commerce put on a series of forums in Bennington, which is where I'm from. And the position of one of the speakers there, who was a member of the Chambers, was, I'm not buying insurance. If I were in Vermont, I wouldn't have to comply with this federal law. That isn't true. Every state has to comply with the federal law. It's just that Vermont is doing it sooner so that we can kind of have a little bit more control over it. And as Richard said, try and modify it to be an actual single-payer system.
Yeah, so when they finally did this federal law, they really kind of gummed up the works.
They did for us.
what Vermont
For a lot of states, a lot of states were very excited about it. But for us, they did kind of gum up the
Well,
works.
yeah, because they just delayed everything.
We're way ahead of almost every other state in the country in terms of healthcare reform. So this was a backward step for us, as was the Medicaid expansion that the Supreme Court kind of turned down. But we're already up to 200 to 300% of poverty for Medicaid, where the bill required it to be expanded to 133% of poverty. So we're treading water now.
You said that the Supreme Court turned down the Medicaid part?
No.
Medicaid expansion. In other words,
for us.
not for us. There's what's called a continuation of effort. So if you're already offering an expanded Medicaid program, that doesn't change. So we're okay. We can keep doing what we're doing. But states like Alabama, Mississippi, and Texas, where you're only eligible for Medicaid if you're 50% of the poverty level, which is $10,000 for a single person. So unless you're making $5,000 a year in Alabama, say, or Mississippi, you're not eligible for Medicaid. In Vermont, you can be part of the Medicaid program if you're making $30,000 a year. So that doesn't change for us.
Well, the Supreme Court opinion is hundreds of pages long, and when you read it, there are lots of technicalities, and that's one of them. That particular one doesn't apply to us. So I hope that answered your question, and I hope that our continuing the presentation answers your other questions, and if not, ask them at the end.
I'm sorry, I wouldn't have asked the question.
No, that's fine. I wasn't. No, we want you to ask questions.
I think these are all the issues that are on a lot of people's minds.
Yeah, they are. I think it was a good discussion.
It's very confusing stuff.
And because it's so confusing, so what's the solution? And as you pointed out, in Vermont, the solution is that we as a democracy and we the people have declared healthcare to be a public good. And that was with the passage of Act 48. And what Act 48 does is it says we have a universal system. That means everyone is included. Oh, sorry. I have such a loud voice that I'm not used to microphones. So the universal system means that everybody is included, and it's equitably and publicly financed because it says that our health care is a public good, just like education, just like our fire departments. So it is publicly financed. It's not a for-profit industry that makes money off of human suffering. And one of the really important breakthroughs about Act 48, which got nationwide attention, was the inclusion of 5 human rights principles in the Act saying healthcare is a public good and here's how you have to administer it. And one of those principles is universality. Everyone has to receive high-quality health care. Doesn't matter what your income level is. It doesn't matter whether you have insurance or not. You have to get it when you need it. And it doesn't have to be the same for everybody. It has to be you get what you need when you need it. And that leads us into equity, which is the second human rights principle, which says that not only must you get what you need when you need it, but that the cost of it has to be shared equitably. And equitable doesn't mean fair, and it doesn't mean the same. It means what each person needs, so that in terms of the financing, people who can afford to pay more might pay more, whether it's through taxes, whether it's through, well, it would be through some sort of taxes because it's publicly financed. The other principles included are accountability and transparency, and these are really important because Green Mountain Care, which is the system we're going for, which is administered by the Green Mountain Care Board, which is headed up by Anya Rader-Wallach, and they're going for a system that has to be totally accountable to the people. In other words, participation is key here because we are a democracy, and this is part of our democracy because it's now a public good. So we each get a say in whether this system is working and in how it works. And Green Mountain Care, the board has had listening sessions throughout the state. You've probably heard about them, and is encouraging your comments. And relative to the dental testimony we heard, I think Richard is right. One of the reasons that they postponed that on last week's agenda was because they had had such an overwhelming number of comments on their website that they had to read. And they also took testimony at Vermont interactive television sites around the state. So our voices are making a difference, and we are the ones that are shaping this system. And because it's a public good, the public, that's us, gets to participate and say what we need. We made this happen a lot of different ways. We made it happen by all of us organizing and making our voices heard. We made it happening by telling our stories to the legislators, telling our stories to each other, looking at each other eye to eye, and talking about the human suffering that we or our neighbor or our relative has experienced, and how painful that is, and how it's not acceptable because it denies people their human rights, and the real cost is in people's lives. And so Vermonters decided to hold the power holders accountable and demanded the human right to health care, and health care is a human right on the international level, and we are probably the only industrialized country in the world that does not hold health care as a human right and have a universal care system. So people told their stories, and they told about not being able to afford things. And I have a personal anecdote relative to dental care. I have a tooth that abscesses frequently because it's left below the gum line and I can't afford to get it pulled out at any one time. And when it does abscess, I call my doctor and ask for an antibiotic because otherwise I get really sick, and it really hurts a lot too. And I called one time, and because I owed my doctor money, they said, I'm sorry, unless you have the $40 for the copay, you can't come in. And this was at the end of the month, and my income is Social Security disability, and I didn't have $40 until the following week. So I couldn't come in, and they said, the office manager said, well, I'm sorry, then we can't see you. You'll have to go to the emergency room. I said, the emergency, do you know how many hundreds of dollars it's going to cost me to go to the emergency room? And she said, I can't help that. So I did go to the emergency room because it hurt a lot and I needed the antibiotic. But the point is that people should not have to refrain from getting care because they don't have the money at the end of the month. Or no, they don't have the money saved up because who anticipated they were going to get a terrible disease or be in a catastrophic accident. And 6 in 10 people in our state have problems getting dental care. People get bankrupted by medical debt frequently, and people depend on their employers for health insurance and sometimes stay in jobs where they're not making enough money to really live on, or where the working conditions are terrible, or even in relationships that are abusive. I know that a lot of the domestic violence shelters have found that people stay in abusive relationships because they need medical care and their kids need the medical care, and they get it through their spouse or partner. So what exactly is this universal health care that we all declared to be a public good in the state of Vermont? As I said before, it guarantees everybody can get the care when they need it. And when we say everyone, we mean all human beings. It doesn't matter whether you're a citizen or not. It doesn't matter your educational level. You're human. You're subject to becoming ill. No one chooses to become ill. And so you should get medically necessary care. It also ties health care to your needs, not to employment, and the law specifically says that health care must be decoupled from employment. It also doesn't require payment at a doctor or a hospital when you go to get the care. There are cards that most countries have that you get from the Department of Health when you're born or when you come to the country. And you go to the hospital or physician's office and they swipe the card, and that's it. The hospital or physician bills the central location for payment, which in some countries is the government, and some countries maybe they hired it out to a contractor, but it's one place and all the payments go there, and you don't worry about paying medical bills. You don't worry about being bankrupted by your medical bills. And it's one unified system. At present, the way that healthcare has functioned before it was declared a public good is that it was a commodity. If you could afford it, you were fine. However, I do know a lot of people that can't afford insurance and can't afford to use it. I know a physician in Bennington who thought he fractured his leg, but he has on his policy a $5,000 deductible. And since he's in a new practice, he instead was lucky enough to be able to call one of his friends who's an orthopedic doctor and say, "Can you see what's wrong with my leg?" And he was saying, if I were a normal person, I would have had to go to the ER, I would have had to get the x-rays, and I would have had to pay it all out of my pocket. What would I have done? My leg was broken. So that's the situation people find themselves in. We know that the healthcare system is a lot like our fire departments. If my house burns down, that's bad for me. It's bad for my community because I don't have anywhere to live now. It's also really bad for my neighbors because what happens if we don't have a fire department and my house starts on fire? And it's burning, and whose house is going to go next? My neighbor's, and the one after that. We all recognize that even if your house isn't on fire right now, you want to have the fire department there in case you need them. And healthcare is no different. We don't want to be just putting out individual fires. We want healthcare as a public good, publicly financed, and that is what Act 48 does. So Green Mountain Care is the system that you were referring to that we are moving toward. And this is a quote from the law. It says to provide as a public good, comprehensive, affordable, high quality, publicly financed health care coverage for all Vermont residents in a seamless and equitable manner, regardless of income, assets, health status, or availability of coverage. And the principles of universality, equity, public good, transparency, and participation are required to be applied to everything that comes out of the Green Mountain Care Board, because in the law it says those are the governing principles. And the accountability, transparency, and participation, as you can see from the language of the Act, ensure that Vermont gets input from not only healthcare professionals, but residents and anyone else who cares to comment. And so I don't know, I think at this time, Richard, did you want to talk any more about the transition to the exchanges?
You know, it's easy to sort of trash the exchange, but there is a way that we can make it work in our favor so that it will help us get to single payer. I mean, we have to live with it, it's here, so how do you do that? So I I think some of the things that the Vermont policy people and the Green Mountain Care Board are doing might help us move in that direction in a halfway decent way. But one of the things that's going to happen is there are programs that are, they're not straight Medicaid, but they're a little bit above it in terms of, eligibility, Catamount Health and VHAP. So in 2014, those programs will be gone. Those names won't exist anymore. They get assumed into the exchange, and so they'll all become part of a general Medicaid program. So that's about 30,000 people that will be all part of this exchange. And then the programs won't have their individual identity anymore. They'll just, people will actually be having what appears to be private insurance on one end, and then on the back end it will actually be money coming from the federal government to pay for it, like Medicaid, based on the person's income. So on the front it looks like private insurance, but on the back, behind the scenes, it's really still the same insurance that they've always had. In some ways it's a smoke and mirrors thing, but it's real. In Dr. Dinosaur, the program for children, which is one of the best in the country in terms of coverage, that's going to stay the same. But one thing that will happen is the way Medicaid operates now is you can't get Medicaid if you're a single, if you're a couple without children. There are certain exclusions. Those exclusions are going to go away, and it will be only an income-based program, nothing else. So that's a big change. Now, the people that are in some of these programs, like Catamount Health and VHAP, if they don't do anything, they'll basically see no changes, but some of the paperwork might change. But they're not going to all of a sudden, they might have new options. They can choose to be in some of these other programs that are part of the exchange. But if the subsidy that some of these newer programs offer is higher than what they're getting, lower than what they're getting now, there's no reason for them to do that. And here's where the problem comes, is that there'll be changes in the co-pays and the deductibles. Now, if you think the earlier part was complicated, this is even more complicated. But essentially what happens is people that are formerly in Catamount Health and VHAP, okay, they think they're in the same program. They don't do anything differently. Things appear to be the same to them. But their co-pays and deductibles, from what we can tell right now, they're going to start changing for some of those people depending on their income. And they could end up in a more unaffordable situation than they have now. And this is what the advocacy groups have been fighting with the Green Mountain Care Board, especially in the legislature. And that's where the whining starts. Oh, we can't afford this and we can't afford that. And when the politicians are saying that, what it really means is we're not gonna pony up enough money to really make a difference in people's lives in terms of the co-pays and deductibles, and so people on VHAP and Catamount Health now are going to get screwed, basically, because they're going to end up having to pay higher out-of-pocket costs than they're paying now. So what we're trying to do, or the advocates are trying to do, is to maximize the subsidies and then spread them around best way possible. So this is sort of a work in progress. It's a balancing act with the Green Mountain Care Board and the legislature and then the budget people and the Shumlin administration. This is politics at its worst or its best. It depends on how crazy you are. But this is the politics of healthcare, and this is the nitty-gritty of it right now, is really boiling down to the out-of-pocket costs for people that will be in the exchange, the people that are actually being subsidized. How is that going to come out? We don't know yet. We don't have a budget. So this is, it's a critical feature of everything. So I think one of the sort of simplified ways to look at the exchange is that it's a complicated, convoluted, screwed up solution, and it's a new problem. It's not really a solution. So we have to do it because we have no choice. we'll do the best we can. We'll try to, I mean, I think honestly in Vermont, legislators and policymakers really don't try to kill people like in other states so that they won't use it. But we try to do the best we can. But this was foisted upon us. We have to do it. So we're trying to do it in a way that will lead the best way to single payer. So part of that may be to prove that a big part of it doesn't work because it's a market-based system, and we'll be able to show pretty clearly that a market-based solution doesn't work. You know, unfortunately, that's at the cost of people's lives and their health. But this is what might happen. And, you know, well, we don't know yet because we don't know the numbers.
When will you know the numbers?
Well, I think it's going to be not for another year. So it probably won't be until this year was the year for benefits. So we're gonna know the benefits package. But the final decision on the cost is about a year away. But I think we're going to know sooner than that, because what's going to happen is we're going to have to see some numbers on dental coverage. We're going to actually see some of the numbers on the out-of-pocket costs. I think possibly before the legislative session starts, if not very soon after it starts in January. So even though we won't have the big picture of total costs, we will have a picture of individual costs, which is really what's important. So we'll know those numbers, but they won't be fixed in stone. And in a way, that's a good thing for advocates and everybody, because we hear whatever we hear. If it doesn't make sense to us or it's no good, it will give us that opportunity that Mary talked about to mobilize and to tell the power brokers that no, we're not going to. We can't live with this. This is a bad solution, and there's too many copays. The deductibles are too high. So the good part of not having things firmed up is that it gives people greater time to respond. I mean, look at this dental thing. I mean, the Green Mountain Care Board was, from what I understood, was pretty much ready not to have any dental coverage at all. And based on people barraging them with their ideas, they had to revisit that, and they had to open up their minds, and they had to change things. What they come up with hopefully won't be just an appeasement. You know, it'll be something real. But so when you hear the Republicans saying, I mean, this might be a good point to make to them to counteract what they're saying. Oh, we want to hear the numbers. We want to see the numbers. We want everything fixed. Well, if you do that, then that takes out of the equation the average person's ability to respond and actually have a chance to change things. So there is some, I mean, there's some good to not knowing the final numbers. There's some good to knowing what the proposed numbers are and having an opportunity to respond to that, which is what we have in Vermont. So I think, you know, it's sort of like the whole thing, the little thing about lemons and lemonade, you know. It's like, okay, so we got some lemons and we're making lemonade, you know. So.
Republicans, which Republicans are you talking about?
Oh, like Randy Brock is like going crazy saying that the Shumlin people and his whole administration, you know, it's all smoke and mirrors because they're not telling us the numbers. And we want the numbers now. We want to know exactly what the budget is and all that. And if that becomes known and fixed at this point, then that'll, I mean, really, it does eliminate the ability of people to have input. I mean, I never thought of that. I'm just thinking of that now as I'm talking, and so, you know, but it does make a lot of sense that you know, that sometimes not moving forward quickly is better than moving quickly because, you know, you have more chance for input. So
So we're riding our time for 5 years, and we're going to get through this for 5 years, and then when do they think Vermont will actually have a good picture of what we'll do in 2017?
well, that will be well before 2017 because I've heard this from people in Washington. I talked to people there and some of the staff people in Welch's office and Bernie Sanders and Leahy, and what they've said is, as far away as 2017 appears, some of them are happy that it's 2017 because what they're saying is it gives us time to get our ducks in a row and prepare. So when 17 shows up, we're ready to roll. You know, it won't be like getting prepared. When 2017 comes and the waivers are there, we already know what we want. Bang, let's just do it. So that's the hope of people that are, you know, especially Washington, but Shumlin too, I think, is that we're not just biding our time until 2017. We are doing everything we can to get ready so that when the waivers show up, that's it. You know, no more screwing around. We're ready to go. This is it. And we already know what we want. So, you know, that's another way to look at it. You know?
And as Richard said, it really is useful because the money, we've gotten innovation grants from the federal government, several of them, over the past 6 or 8 months to put into the IT category, information technology, which we're really going to need because if we're going to have one of these cards where people can get their health care, you know, paid for by swiping the card, there's a lot of work to be done. So as Richard says, there are, even though the exchanges are difficult, in some ways, it's giving us extra money to sort of set up our system to have it be ready for functioning.
Yeah.
Are you gonna pull it through, like a Medicare card goes through, but are you gonna ask for the copay up front?
No, that's the whole idea of the way that a public good and public financing should work is that there shouldn't be a copay.
Well, I know, but there is gonna be one for 5 years, so are they gonna have any cards at all until then, or not?
That I don't know. That's something the Green Mountain Care Board hasn't yet decided. And if I could,
You said no copays. He said we didn't figure out what the copays were yet.
What I'm referring to is the time now between now and 2017.
Yeah,
but even in 2000, we don't know if any system that we have will have copays. I mean, you could design a single payer system with copays. Most people don't want to do that, but we don't know. But we know for sure that there will be copays and deductibles for the next 5 years, more than likely.
So the law doesn't rule out copays.
well, actually it does in some instances. The law does say that for chronic conditions and for certain kinds of treatments like mental health and substance abuse, and there's a whole list of conditions where the law specifically says there can't be any copays once we have the universal health care. Whether there will, preventative medicine is one, whether there will be, if it's a true universal care system, what I was referring to is a universal care system does not have a copay. You know, if you go to other countries where they have truly universal health care, they don't have the copays. So that's why I realize it sounded like we were saying two different things,
But
I
Act
think we
48
were in
doesn't
two
exclude
different time periods.
Except Act 48 doesn't exclude them except for certain categories.
Well, it's not Act 48. It's actually the federal law, and most of the exclusions for copays are through Medicare. A lot of them. Medicare excludes copays and deductibles for colonoscopies, yearly health exams. There's a list, like Mary said. So it's sort of precedent setting. It's a good precedent. It's like, okay, these are so essential that we've recognized that copays and deductibles are a deterrent to health care.
Which is the same reason why they included a lot of those things in Act 48.
So then as you're arguing benefits, then before you get to talking about numbers, so you may look at what the list of benefits are where you would exclude the copays up front, and then talk about the numbers
And
later.
that's the Green Mountain Care Board has in fact done that. They've looked at what it would be for copays, what it would be with premiums, what it would be without, and that's all part of the financing part, which is the next part they're going to look at. But as Richard pointed out, until they know what the benefits are going to be, they can't possibly work on the financing part. And one more question, and then we'll go ahead.
I just am not clear on what the exchange is.
Okay, I think before, what it is the exchange is a pool of insurance companies that the federal law said every state has to have this insurance company set up that's like a travel website kind of, where you can say what you want for insurance and it'll give you the lowest price. And then you pick it. And the state is allowed to decide what company or companies they'll deal with in these insurance exchanges. And so our state has decided on 3 companies, we think. Is that a final decision?
No, they have to bid on it, and there's all the
Yeah.
others, so.
But they're entertaining from 3 different companies. And it has decided that there won't be that same kind of insurance sold outside of that, what they call an exchange, because that'll just raise everybody's prices.
You mean nobody else can do business in the state of Vermont?
No, nobody can sell the same kinds of policies in the state of Vermont. Now, if adult vision, for example, isn't included in the exchange insurance package, then somebody can sell that. But that was a decision towards the end of the session.
The exchange, if you said to the legislators in Washington, come up with the most convoluted, complicated way of reforming healthcare you could think of, this would be the answer. You know, because it's so messed up.
So this all demonstrates the exact reason that we need to shift our thinking from health insurance to health care. And it is a big shift because I don't know about everybody else, but I am, thank you. I don't know about everybody else, but I grew up with thinking about health insurance being health care. I mean, you went to the doctor, you had health insurance. I didn't know of any other way to do it until I started finding about all the other countries that did it differently. And so because we all know that just having insurance does not mean you can have health care, and it certainly doesn't mean you can have health care for your whole body, including your teeth or your eyes or whatever, what we really need is health care, not health insurance. But it requires a big shift in our thinking, at least for me, and I think for most people involved in the subject, because we're not used to thinking of it that way. So in order to accomplish that shift, it's going to take all of us, the people, getting in touch with the people that are involved. In other words, the Green Mountain Care Board, which develops all the budget processes and benefits packages. Of course, the governor and the legislature. And this is a timeline which we could have shown earlier, but in 2013, the way it's scheduled right now, they will be debating financing plans. And 2017, and these are all the latest dates, as Richard pointed out, would begin the universal health care. So if we want to make all of this happen and we want to actually move from health insurance to health care, it requires all of us to actually participate in our democracy, because if I write a letter to my legislator and I say, this is Mary Garish and I'm not getting the health care I need, they go, that's nice. So it's kind of like I'm out there all by myself. So, but then if Sheila and Kira write a letter with me, okay, now we've got 3 letters coming in. Well, that might get a nod from somebody, you know. And what we really, the way we can look at this is, and I did this actually when I was young to my younger brother. I don't know if you all know about what a teeter-totter or a seesaw is, you know, that you go up and down when your kids, one on one end, one on the other. So my brother's younger, and he's now bigger than me, but he used to be a lot smaller than I was. So if I put him on the teeter-totter and I got on the other end, he was stuck way up there in the air. And he stayed there because it didn't matter how hard he jumped. I wasn't going anywhere because I was so much bigger. And that's a lot like what happens to us when we're talking to people in power. There's one of us saying something or doing something, and we're up on the top of that teeter-totter, and we've got rich lobbyists and other people down on the bottom, and we're not going to move it. But if we get 20 of us up there, it might start to move just a little. And if we get 500 of us up there, it's going to start to waver. And if we get thousands of us up there, you know who's going to be up in the air then? It's not the people. It's the rich lobbyists. And so that's why it's going to be more and more important as we move forward. There are lots of decisions that the Green Mountain Care Board is going to make. For example, what financing sources are they going to use? Is it going to be income tax, payroll tax, some combination, or some other tax? How much money would come from each of those things if we use more than one? Will we have dental, vision? What about hearing and hearing aids? All of those things are things that are going to be decided by the Green Mountain Care Board. And another really key decision is whether immigrants living in Vermont should be included. They did a study on that, and the residency requirement in Act 48 currently does not say that you have to be a citizen of the United States. It says you have to be a resident of the state of Vermont. So that's something we need to consider, because there are lots of folks who are here supporting our economy and paying their taxes, and they need health care too. Yes?
Is there a time requirement on that residency?
There is. No, actually, what it is the residency portion says that you have to indicate an intent to be a resident of the state of Vermont, which means you have to have an address where you can be contacted, and you have to state that it's your intent to continue to reside here. Now, if they find out that that intent is falsely stated, there are huge penalties, both financial and otherwise, and criminal in the act.
So is it tied into sort of the residential, non-residential tax piece as far as how they're, because people are not residents, but they have.
But they pay
But
taxes.
they have, well, yeah, but they're not paying full taxes. They're paying non-residential taxes. People that are not residents that have a second residence here.
Okay.
Reside
Right.
in
But
another
people who
state.
are here working on the dairy farms and in the restaurants are paying full taxes.
But I'm just wondering.
I see what you're saying.
I'm just wondering if they're tying it into.
Well, that's one of the things that the Green Mountain Care Board is going to decide, and that's one of the things that we all have to give input on, what we think they should do about that. And so that's going to be one of the key decisions coming up.
They won't be.
They're not covered. She's talking about people whose primary residence is another state, but they have.
Oh, I'm sorry, a second home here. The only time they would be paying is if property taxes were used as a source. And in fact, there was a suggestion about use of property taxes. However, in the listening sessions that the Green Mountain Care Board summarized, the vast majority of people did not think property taxes would be a good source of tax revenue for universal health care. So that's the only way. I'm sorry, I misunderstood your question.
But wasn't the question whether they would be covered?
They won't
Whether
be
they
covered.
would be
Well,
eligible?
if somebody's, I was just trying to figure out if they were tying it into sort of that tax code of resident, non-resident, which begs the question that it is confusing with the migrant workers,
Right.
people that come in for periods of time and work as,
Right.
and that's probably another category. But there are people who have, homes here that have, that's what I was trying to.
And you're asking whether they would be covered by the universal health?
Well, yes, but I'm trying to figure out because this may be one of the complicated things about trying to figure out how to do that, because you've got the issue of the migrant workers and the people that come in and out that need health care coverage.
Right.
And then you've got people who might be taking advantage of getting health care coverage in a state that they're not.
But they
paying
wouldn't
full
be
taxes
able,
in.
but the people that have second homes here would not be able to do that unless they declared Vermont their primary residence
That's what
and paid full income
That's what I was
taxes.
getting
Yeah.
The migrant workers will, they don't have an intent to live here.
Yes, the
ones that just come.
So actually,
I think so if we could just save the rest of the questions, I'm sorry, but for the, towards the end. And so the principles are going to be, and this actually addresses exactly what we were just talking about, universality includes all immigrants. And it's, for example, in other countries, if I go to Britain and I get sick, I don't pay anything. I get health care. And actually, that happens in other countries too.
Let me just make one point there is this new, because I've been working with people with this new Obama initiative with immigration, people that
Right.
weren't born here that came
The DREAM Act.
and unfortunately what Obama did a few weeks ago is he issued a directive that says even though these people successfully apply under this new program, they will not be allowed to have health insurance in this country.
No, actually, that wasn't, that's in the Affordable Care Act itself.
No, I'm not talking about the Affordable Care Act.
He's talking about.
This is the new immigration policy that Obama created. It would apply to mostly young kids that came here when they were young and they've been living here for at least 10 years.
And they get to,
And they apply, they get a Social Security number. That if they pay some money, they can also get a work permit. They don't get citizenship, but the hope was that they would be able to get insurance like Medicaid. Well, Obama issued a presidential directive a few weeks ago denying anybody who successfully applies to that program access to health insurance in this country.
Right, which is because the federal law, they do get access to certain kinds of health care, but it's because of the and there are actually international
No, they have
treaties
no
on.
access to health
Okay,
care
all
at all.
right,
I'm working with people like
Yeah,
that
me
now.
too.
His thing is different from the healthcare thing.
Yeah, I'm not talking about the
It was
ACA.
about college. It was
Yeah,
ability to go to college and
Yeah.
Yeah.
and so I
Well,
didn't.
well, we should. I know there are lots of groups through the Human Rights Network that are very active in this, and we've been down in Washington recently.
Can I
So
ask
we
you
should just.
a question that is important for me?
Yes.
What do you intend to achieve from this meeting?
What we intend
What
to.
will make you feel that you have succeeded?
What we intend to achieve from this meeting is to bring folks together and to have people ask questions and to then act on their belief that healthcare is a human right and become active either by putting up a lawn sign, which you can get over here, by making calls to the Sergeant at Arms when legislation comes up on the floor, by joining your local organizing committee and letting your friends and neighbors know how important it is to express your opinion.
Can we make it very simple? I agree completely. I can relate to this one.
Yeah.
But the conversation and the repeat of the question and the vagueness of the answers that I can absolutely understand is not. That's not my job. But I would love to be able to put a sign or something like that. But frankly, to listen to you people who have been involved with it and how difficult it is for you to do that, I'm very grateful that you do this work. But I don't want to do it.
No, I understand, and you don't have to do.
No, I won't. But
That,
I would love to pick up the kind of thing I can do is to take the piece of it.
That's exactly right.
That's fine.
And there are postcards there that you can sign.
Okay.
And I appreciate that, and I understand that this is and thank you for bringing this out because this is a very difficult subject to talk about and try and answer questions about because everything is so uncertain.
But you have
That
more power than you realize in Vermont, because if a
No, my point is not. You are doing the job.
Yeah, but
and you are doing. It's not. I'm not going to have the capacity that you have had, especially for you. You have been working for so long at it. But what you ask me to do, I can do it.
Right.
And I agree completely with your objective. But the nitty-gritty that you are going through, frankly, is above my head.
No, and I'm not asking that. All I'm saying is, if you wrote one letter during the legislative session or one email to one of your representatives from somebody who they don't consider one of the usual suspects, like us, that goes a long way.
So,
They really listen to
so
that.
if you do that and you put up a long sign and there is a postcard there that you can also fill out, which would be great because that is going to be sent to the legislators. And I'm sure that the organizers here in town, I'm sure Sheila will be in touch with you if you want to sign the sign-in list. If there is a time when it's a good time to send emails, I'm sure Sheila can let you know.
Actually, I hope we are doing exactly what should happen. We are mobilizing people, but use people in what they can do, because these details are really far above my head for me to have any input.
No, I totally understand that. Did you?
Just one other observation. You had me
Sure.
early on because you said it's not just health
Right.
and the body. It was also vision and dental.
Right.
And then I saw one little word about hearing, but then all of a sudden we heard nothing more about vision or anything else. It was all dental. Not to say that it's not important.
Right. No, but you're right.
The point is, it's the person, the whole
That's
person.
right.
If you can't see, if you can't hear, you're not healthy.
That's correct. And that's really the key aspect of universal health care is that, and that's what equity says. You get what you need when you need it. You don't get what I need. So if it's dental, if it's vision, if it's hearing, if it's psychiatric, if it's substance abuse, no matter what it is, that's exactly right. And
But I kept hearing, the
because we were
reinforcement.
saying dental.
Dental.
You know why we were doing that, which may have been a mistake. Because they're just considering that now, and they're not at the vision or the hearing yet.
Because of VPERG.
Yeah, yes, and VPERG sent out a thing about dental and to focus on it.
Email list.
Right,
You're in.
that's right. So, but you are absolutely correct. We are not just focusing on dental. The whole idea is to focus on the whole person instead of just one. And thank you for pointing that out. Yes.
So, speaking of the whole person, is there anything written into this?
Thank you.
So I want to call it an initiative. Is
Yes.
it an initiative? Am I
It's a grassroots movement.
Okay, so is there anything written into this initiative or this movement that speaks to holistic healthcare?
Yes.
That supports holistic practitioners, so that we're not just chopping the body up into
Yes.
vision and hearing and dental.
Yes.
That there's holistic practitioners, preventive practitioners that are actually being utilized within this reformed healthcare.
Absolutely. In fact, the Green Mountain Care Board had an entire day of testimony from alternative medical practitioners, is what they called them, whether it was nutritionists or whether it was chiropractors or people that practiced Reiki, all different sorts of alternative medicine. And they had a whole day of hearings on that because there was such a great expression from the public about how much those things were needed. And of course, the Blueprint for Health, which the Act says they're going to try and build upon, includes some of the alternative care providers. So the real question, I think, is certification. Richard, do you have any other updates on alternative care providers and certification?
I mean,
yeah.
It's always a struggle. I mean, the politicians want to equate it with money, but if you look at the numbers, there's something like 80 or 90% of any given population in this country uses one of those alternative, what they call alternative, at any given time, and the amount of money.
Yeah, I wish that we would even get rid of that word alternative, because
Right.
that means it's
I understand. Yeah.
It should just be holistic.
Correct.
Healthcare practitioners.
You're right.
Which means they are considering the entire person.
Yes.
They're looking at every aspect of that person's life.
I agree.
Whether they're employed, whether they're going through a divorce, whether they're whatever. All of those things impact our health and our well-being.
Yes, I totally agree.
Unfortunately, like the Green Mountain Care Board and the politicians, they try to equate all this with money. And as much as they pay lip service to saying that it's really important, I just don't think they get it most of the time, that how important it is to people's lives to have access to this kind of care, It's sort of like we're making progress, we're chipping away because they're hearing more about it, but it's a struggle. It's a big struggle, unfortunately.
So I would like to get involved in that front. I am under VHAP. As
Yes.
a single mother, I have VHAP. My son has Dr. Dinosaur, but I don't use it. I mean, I do my yearly
Sure.
visits, but I go to alternative
Right.
care practitioners who don't accept my insurance.
That's correct.
So all my health care is really coming out of my pocket.
That's right. And that's very difficult. And
And I have insurance.
yes, well, a lot of people have insurance and don't use it, can't use it.
Like right now, I'm working for the Blueprint, and I'm helping people manage chronic diseases. And a lot of the people that I'm working with want to go to an acupuncturist, they want to do racing, they want to do all this other stuff. And they can't afford it. They can't go to these people. I'm trying to find money to just help them do it. But I'm also trying to change the system and show the people that are running the program, say, look at, because I'm going to keep statistics and anecdotal stuff, and say to them, look at all these people we're dealing with. This is what they really want. This is what's going to make them better, but they don't have access to it. So we'll be able to show them some of this stuff, too.
I would like to know how this group got organized, or if this is a break-off group from what we've been going to when we were working up through this. I'm confused.
Okay, I can tell you. When we were working through this, the Vermont Workers Center had the Healthcare as a Human Right campaign.
No, I'm talking about when I went to the meetings at the VM at the hospital where they were explaining this program to us. I went to all those meetings, and this is not part of that.
What program?
I don't know what program that was.
Well, we listened to Dr. Wu or whatever his name was.
Dr. Shaw.
Pardon?
Dr.
Yeah,
Shaw.
Dr.
Oh, that was a program that the state put on, maybe? Yes, okay.
No, that was the Vermont Citizens Campaign. What that was about was Act 48. That was all about the bill that created.
Right.
Yeah.
So where did this start?
What's this?
That we're here tonight?
This is the bill. This is the bill that passed. It started out as H2O.
No, you're not.
The organization she's asking. Are you asking?
I have no idea why I'm here tonight, because
Okay.
I thought this was just an extension of what we went through with all these informative meetings about how that was going to come about.
All right, I don't know what meeting that you went to because I wasn't there, but.
Well, all the doctors were there.
I can help.
Okay.
Yeah, because I went to those, and they're the ones you put on,
Yeah.
Richard, and your organization.
Yeah.
But at the same time, Vermont Workers Center has been working side by side for many years on these very issues. They work on a lot of issues, but they decided that universal health care was an important issue, and they did a lot of work, a lot of grassroots work to pass this bill that happened. So that's who this organization is tonight, putting this on, right? The sponsor of the meeting tonight, I'm assuming, right? I came a little late. Is the Vermont Workers Center?
Well, no, it's actually a coalition because what happened was Richard's organization and our organization and a bunch of other ones that you heard right at the beginning decided that this was such a crucial issue that we were all going to combine our efforts.
Okay, so is this the first time you're meeting?
This in Brattleboro, yes.
Okay, so
As
I
a-
really am feeling really stupid because
No, not at all.
Really, this is an extension of what Richard's
the
group were doing
coalition,
before.
yeah.
And an extension of what healthcare as a human right was doing. We're just joining
This
forces.
is to give you an update from those other meetings.
Yeah, but you went to the workers thing, and I'd never heard of that, and I thought I'm not in the same place.
Very,
Oh.
very important, significant, working side by side with Richard's. So who are the other coalitions of groups?
The other
I'm
coalition.
sorry, I came late, so I didn't.
No, it's fine. Let me just read them off here.
Oh, yeah, there.
There's the Alliance of Retired Americans, the Federation of Nurses and Health Professionals, AFT, Local 5221, the United Professions of Vermont, which is the AFT union, the Vermont AFL-CIO, the Vermont Center for Independent Living, the Vermont Cancer Association, Vermont Early Educators United Union, Physicians for National Health Program, PNHP, the Vermont Healthcare Ombudsman, the Vermont NEA, which is the Teachers Union, Vermont Healthcare for All, VCCH, Voices of Vermont Children, and VPIRG. So all those organizations came together to form a coalition called Vermont Leads. And of course, Single Payer Now and the Workers Center. To try and reach on a grassroots basis more people so we could make sure that when this law, when the Green Mountain Care Board makes decisions, there are more people involved. And you can get involved by some of the things I already mentioned. And I should mention that a lot of these same organizations have candidates forums coming up within the next month or two, where all of the legislative candidates for our individual areas will, on what day is it?
October 9th.
October 9th.
Will be Wyndham County.
For Wyndham County. And that's going to be a meeting with all the different legislative candidates where we will come and explain to them how important human rights are to us and how important healthcare issues are to us and participation of the public and the people's budget and other things.
Where is that?
It sounds so extremely vague.
Okay.
Maybe some examples of what it was like last time?
Yeah. So the candidates forum last time, what we did is we invited the candidates that were up for election, and we were dealing mostly with the issue of healthcare at that time. So we asked the candidates, each of the candidates at the beginning, if they believed that healthcare was a human right, and they said either yes or no. And most of them in my area said yes, but there were some that didn't. And then people got up and testified and shared their stories with the candidates. Various other organizations like Vermont Center for Independent Living participated, and they stood up and they talked about how important healthcare was for the members of their organization.
Okay, so the one you have coming up, I just need, this is taking so long, that's why I wanted to
Okay.
finish this up. They're coming again, and again we're going to be invited to be in the audience, ask them questions.
The candidates, the legislative candidates, not the people, not the doctors and the...
No, I just said those people are going to be invited.
Right.
They're going to be on a panel, and
Right.
we're to be in the audience representing these different groups, and then we are to ask questions.
That's correct.
Okay.
What do you need candidates? Because nobody's running against each other in Wyndham County
Yeah.
locally.
Well,
Everybody
if they're running on a post, they still have to run. I mean, people still have to go vote.
What makes you think they're going to show up?
They always show up.
They always do.
Oh, do they?
Yeah. Oh, yeah.
They want to hear what we have to say.
I saw somebody was shaking their head about when we talked about how insurance companies' competition doesn't actually make the rates cheaper, it makes them more expensive. Is that it? Does anyone want
Can you explain
a simple
why that?
explanation of that?
Yeah.
Insurance companies have a different profit model than any other kind of business. Most kinds of business in the free market system, if I go to the baker and buy a loaf of bread, the baker wants me to use that bread because otherwise I'm not going to come back and buy more. If I buy health insurance, they don't want me to use it because the only time that they make money is if I don't use it. And the other the competition aspect is that with bakers, if there's 5 of them in town, they're probably going to try and undercut each other on their prices. And they'll still make money maybe. Insurance companies can only make money if you don't use their product. So when they insure people, they have, let's say, this group of, let's say 100 people, just picking a number, 100 people. And of that 100 people, 10 of them are going to use it a lot because they're really ill or they have a chronic condition. And there's probably 10 or 20 on the other end that are never going to use it. And then there are the in-between people who might use it sometimes. So the way that they offset all that risk of the people that are using it all the time is by having more people that don't use it. So the bigger what they call risk pool, or the more people that are insured, the more they can offset all those risks and the more money they can make. But the more insurance companies that there are in town, the fewer people they're going to have, right? Because some are going to go here, some are going to go there, some are going to. So that risk pool, which is the only way they make money on having people not use their services, well, that and denying claims and stuff, but that risk pool is going to be a lot smaller if there's 10 companies in Brattleboro than if there's only one. So it's very strange. It's almost like counterintuitive because no other market system or profit model of a business operates the way an insurance company does. So even though it's generally true that competition drives prices down, with insurance companies it does what they call fragment or break up the risk pool so that it actually drives prices up to have more insurance companies in competition.
And what makes it even worse is the actual provision of health care competition does the opposite too. So use a similar example, but like if there's 5 appliance stores in town, the price of a refrigerator generally will go down because they'll all try to outdo each other. If there's 5 hospitals in the town, the price of healthcare goes up instead of down. And the more hospitals, the price keeps going up. And the reason is very simple, is that use the lab test for an example. It's cheaper for a hospital to do 10,000 lab tests than 1,000. The more you do, the cheaper it gets. So if the market is 100,000 and you only have 20,000 as opposed to the 100,000, your cost per test is higher. So the more hospitals you have, the higher the cost of the test. So that's why competition doesn't work in healthcare. I mean, people don't explain that because they think it's too complicated, but it isn't all that complicated. But competition in healthcare drives prices up, doesn't drive them down. It doesn't work. It's like I tell people, we're not refrigerators.
So isn't there a meeting tomorrow night with the retreat and the hospital?
Oh yeah.
Isn't that an example where you're trying to get people organized to come and?
That's like the community health needs assessment.
Oh,
The requirement by the state to present what the institutions are doing for their plans.
But they're going to be talking
right.
about these kinds of things. So
Yeah.
that's when you're talking about organizing people.
Right,
And
people
showing
should
up
go
where
there,
the people,
absolutely.
The people are.
That's a good
That's
opportunity.
the kind of thing that you should be getting
Absolutely.
people to go to things like that, because this is not working without them being like this with the hospitals too, correct?
Right.
Yeah.
Right. Nothing has changed there anymore. That they're more.
Well,
And
the
got that
hospitals are-
mental health there too to advocate for. Because I just want as I continue to follow this and everything, you did make a difference with getting everybody to show up and talk. And I watched it on TV.
Yeah.
Where everybody around the state.
You're always going.
Late at night, but I watched the whole thing, and it worked.
It did.
It worked with getting. I mean, it was a focus on dental care, but as a result of that hard work, okay, they are considering it now. They are, and that was activist work on your part.
And the same thing can happen with other things.
Well,
as they
that's it.
consider.
But you gotta show up where they are.
That's
I don't have that much faith anymore in that the next steps are hanging out with the legislators, because I think they
No.
feel like they did their part with, they got that bill through. Now they're going to kind of, there's going to be a few of them are very interested about how this is getting paid for.
I don't think the hanging out with the legislators, I agree with you. The whole
It already got
the
passed.
whole idea of the grassroots movement
Mhm.
is that it's not a top-down structure. So it's not like meet with your legislators and make them write, tell them what you want them to write and then tell them to pass it. This is a bottom-up. This is thousands of people saying, we want health care and we want it now, and you figure out how to give it to us. Or maybe you won't have our vote next year, and maybe you won't be in the legislature. So this year they have 2 issues that they have to deal with under Act 48. One is the benefits and the other is the financing. So they are required by this law to deal with those in one way or another. And it's partially up to us how they do it and when they do it.
Yeah, but it will be certain committees now that will work on it, not the whole body of legislators.
The body of legislators are the ones that are going to approve it or amend it or turn it down or whatever. So we need to, yes, interact with the committees, but also keep the pressure on our legislators to let them know what we want.
You know, like Richard, are you like on that exchange committee now? Do you get all their?
I get the correspondence, yeah. So.
Hmm?
I'm not on any committee, but I get the updates and all that.
Because that's the big one now. Now that they got over $2 million.
Yeah.
That whole group that's working on the exchanges.
Right.
That's not. As much as we may not like them in their, it's all about insurance. It's real.
And then they're
Well,
going to hire the navigators. That's the next.
Yeah, the navigators.
Navigators will do the next thing.
So are people from your Vermont Worker Center on that exchange?
No. Oh, no.
You getting?
There aren't any advocacy people or policy people that aren't that are on that exchange commission.
It's easy
From
to get
like
on it.
individual.
I'm on it. I'm on it. I'm on it.
They weren't picking. Are you talking about the state commission?
Yeah, they send out. I just recently got on it because I went to an event that was once again poorly.
If you're talking about the mailing list, yes.
Mm-hmm.
If you're talking about the people that do the decision making, no.
Well, you go and you influence, and you go to these
Sure.
events. That
Oh,
they
yes,
put
we are
So
definitely
Vermont
on that.
Worker Center's on that.
I misunderstood your question. I wondered if I thought you meant do we have a representative on the actual commission?
Mary, I think Abby had
Yes,
a question. She's
go
been
ahead,
waiting
Abby.
really patiently.
I am just wondering why there's so much, like, everybody always says it's too expensive to have universal health care. With the example, like what you were talking about, how, healthcare costs go up as there's more providers. And then the other piece is that, the insurance companies are making so much money off of it. I just don't understand why, like, and if every other country can do it,
Why aren't we?
like, why doesn't it, financially, why don't the numbers play out?
The numbers do play out in the other countries. We spend more than anybody else, and our health outcomes are worse.
Right.
So why are we still here? Who knows?
Okay.
Is the answer.
Just bogged down in bureaucration.
Well, I actually think it has to do with power and wealth, because the insurance companies pay. I can't even. I wish I could remember the amount. Richard, you might have a better handle on it, but it's just an absolutely phenomenal amount of money every year to the lobbyists.
The lobbyists, sure.
And I always think if they spent on one day to actually heal people, what they spend in one day on lobbyists,
right.
Our health outcomes would be better.
Well, the big difference between us and all those other countries is they've had many, many big, broad public discussions among all the country people about the role of healthcare in the society. In our country, the default position is that healthcare is a commodity, and it's a sacred thing in this country that you don't mess with the free market system, even when it comes to healthcare.
Sure.
We haven't broken through that wall.
Right.
And we have yet to have a big national public discussion. Having an election and all that crap that goes with it isn't a public discussion.
Ellen?
I also have a comment about that, which is there's a whole history of how we got here.
Yeah.
And I'm not going to get into the whole
Right.
history, and I'm not sure I even have all the details right, but Truman was really close to getting us on a national healthcare system. And there were forces that came together to make sure that that didn't happen, and that set us on a certain course that wasn't, part of that was about health, like not getting, they were the people who coined the phrase socialized medicine to scare people about it, but it wasn't really about health care. it was about other power that they didn't want to let, it had to do
Right.
with labor issues.
Yeah.
So there's a whole history about
Right.
how we got to where we are, and then the whole idea of universal health care, which had gone through in all these other developed countries,
Yeah.
didn't happen here because it had been tarred as socialized medicine, and that was coinciding with the rise of McCarthyism, so it got this label on it
So,
that made it,
And
I'll stop there.
are there any? Yeah.
Other
Maybe
questions?
some type of a closing.
right, so and I just wanted to say that also in other countries, in a lot of other countries, insurance companies are nonprofit companies, and so that makes a big difference too.
In
So-
Canada, when they switched to the system they have, it was a little easy because all the insurance companies are nonprofit.
So I think in terms of wrapping it up, I would just say, everybody, and you've all talked about the importance of getting involved and participating, and we all have this opportunity to fix our healthcare system. And so I was really happy that we had so many interested people here to commit to fixing that system. Richard, did you want to say anything?
No, it's a